Hi everybody, I'm Dr. Michael Nusbaum.
And I'm Dr. Daria Klachko Totten.
And welcome to
HealthTalks.
HealthTalks. So what are we talking about today?
Oh, today I want to spend some time, I want to spend like the entire episode here today speaking about hormone therapy.
Big issue.
Yes, and I think it's, had a bad rap in the past, so I just want to kind of go through it to be able to provide some insight and get some valuable information.
Well, you're going to be talking about female hormones.
I'm going to talk, I am the female expert.
Just to be clear.
Yes, so female hormones, yes. So what I want to talk about is hormone therapy for women that are going through their transition. And I want to provide some insight so we can all kind of make decisions, and if we're going through symptoms of the menopause transition, such as hot flashes, vaginal dryness, sleeplessness, which is a tough one.
Absolutely.
And sometimes if you're not sleeping, that kind of rolls into all other problems too.
Very true.
Can lead to mood disorders and brain fog, amongst others.
Which both can affect your personal and professional relationships.
Oh,
very,
for
very
sure.
Important.
Yes, for sure. So hormone therapy was also known as hormone replacement therapy, but we call it hormone therapy now because we're not really replacing something that isn't supposed to be gone. So our bodies are geared for having higher levels of estrogen and progesterone during our reproductive years, which make out about 40 years of a woman's life. So once we're at a place where our bodies are kind of like, maybe it's not as safe to be pregnant or have child rearing, or our hormones start to decline. And that's where you make the decision whether you want to take hormone therapy. Hormone therapy can be given as just estrogen. So estrogen only, or a combination of estrogen and progesterone.
So why do women need both estrogen and progesterone if they still have ovaries and uterus?
Very good question. So estrogen alone is used primarily for women who do not have a uterus or have had a hysterectomy. And this is because if you have a uterus and you just give estrogen without the progesterone, you can increase risks of the lining overgrowing in the uterus, and that can increase risk of uterine cancer. So women who have a uterus who want to go on hormone therapy need to be on both estrogen and progesterone, because the progesterone kind of protects the uterus and really reduces the risks of uterine cancer.
Right, so this is different than a patient who maybe had a complete hysterectomy. They don't have their ovaries and they don't have their uterus. Yeah. So tell me about that. What's the difference?
So a woman who's had a hysterectomy without and her ovaries, depending on what stage of life she is, if she's still in the reproductive ages or not completely through the menopausal transition, removing those ovaries puts you in a really low estrogen state pretty abruptly. There's no gradual decline, and those people tend to be, extremely symptomatic on the onset because their bodies are used to having a lot of that estrogen.
Right, and I've seen a lot of patients who come in, they had a hysterectomy, and all of a sudden they blew up. Weight just came on and on and on. They couldn't stop it.
And we see that a lot in midlife. With hysterectomies and without, it's just a harder time for us. Our metabolism kind of shuts down. Our hormones are decreasing. There's a lot of changes in our bodies, and can all lead to increased weight.
So another question. What if they just had one ovary taken out as opposed to both ovaries? Does that decrease the hormones substantially if you just have one ovary taken out?
If you do, it can. The other ovary can compensate and produce, but you do see some people that do feel a little bit of the estrogen depletion from removing one. But that's to say if that's in a patient whose ovaries are still functioning well as far as producing estrogen and progesterone. So if you have a woman who is already through the transition, you remove the one ovary, you probably won't notice the difference.
Gotcha. And what about when you take out the uterus but you leave both ovaries in? So hormones are still going?
Yes. So you'll see that the hormones will still be going until that person would be naturally going through the menopause transition. So it might come on a little bit earlier than most if you take the uterus out, but most of the time, they transition through it just the same way.
Gotcha. Sorry, go ahead. I didn't mean
it's okay.
I'm sure you guys have.
Sometimes.
Yeah, I'm sure you guys have those questions. There's lots of patients out there that had all different surgeries, so we just want to cover everybody. All right, so
I'm happy to. So for hormone, so for menopausal symptoms, so some of these very symptomatic going through the transition, which a good percentage of people are. So 80% of women will get hot flashes, and the hot flashes can be extremely distressing amongst all the other symptoms that I have mentioned. So hormone replacement, there's a lot of different options for help, but hormone replacement therapy is the gold standard to help with a lot of those symptoms.
So what are the options on how to administer the hormones?
A lot of different options.
Okay.
So when we used to have just oral meds to help with the symptoms, we now have patches, sprays, gels, vaginal rings. There's all different ways. Implants, yes, and there's all different ways that we can get the estrogen into our bodies that might be safer, even safer than taking a pill.
So I know that with my male hormone replacement patients, I don't recommend that they use the gels if they have young children in the house, because I don't want getting those gels onto the kids. Is it similar for you?
Yes, I mean, you don't want to have the gel rub against your pets or children, and you have to just be a little bit more careful about it. There's also patches, but we like that way, the transdermal approach, because it limits the amount that you have to worry about the gut absorbing, and it also skips the first bypass through the liver. So we kind of see that those ways might be a little safer in administrating and maybe lower risks for clots and some of the other bad things that can happen. Low risk bad things that can happen.
I was going to ask you, what are some of the negative side effects of hormone replacement?
So negative side effects, as far as side effects, you can have headaches.
Okay.
Some women, when they start on hormones who have a uterus, might experience some vaginal bleeding from the beginning, which is not, the best thing, but that usually goes away with time.
Spotting or actually seeing their period?
I mean, most often spotting. It kind of also depends on where you're starting them in their whole hormone process. If they're a little closer to their last period or still transitioning, you might get a little bit more bleeding.
So is the bleeding a reason to stop or cut back on the hormones, or you just...
So generally it's kind of expected that might happen from the beginning. So light bleeding, a little bit of bleeding that doesn't last long is something that's kind of expected. Heavier bleeding, more prolonged bleeding after you've been on it for a while, definitely things that need to get checked out. I would say, any kind of bleeding, let your doc know. But it is expected for some women to have a little bit of bleeding from the beginning.
So I always get the question, well, I know I was thinking about doing female hormone replacement, but doesn't that cause cancer?
So, we had this big study that was done. So when I first started seeing patients, which was a long time ago.
How many moons ago?
A long time ago, because we went to medical school together, so we both know it's a long time ago. We were putting basically women that didn't have any contraindication to hormones. We're putting them all on hormone replacement therapy because there's a lot of benefits, and we were feeling pretty good for the most part. The study came out over 20 years ago. That was from the WHI, and it was kind of looking at women on hormones, and the study wasn't even completed because they realized, oh my gosh, more people are getting breast cancer, there's more history of cardiovascular problems, and they kind of withdrew the study, and that created a frenzy of fear.
Okay.
Everyone was calling the office, and everybody's coming off the hormones, and patients and doctors also were nervous to prescribe it.
Sure.
So I think the pendulum is now swinging a little bit back more to looking at hormone replacement therapy, because that study's been looked at, and really, gleaning off of that study is wow, it's not really that dangerous as that study had shown. And with the right people, the right patients to prescribe it to, it can really be safe and add to quality of life from women that are suffering.
So my understanding is that it doesn't actually cause cancer, but if you have cancer that has estrogen receptor positivity or progesterone receptor positivity, it could accelerate the cancer.
It could promote,
but not actually causing the cancer, but just making
and that's the general thinking as it is. So, you wouldn't want to prescribe this to somebody, of course, who has breast cancer, active breast cancer. You also worry about, like with the oral contraceptive pills, hormone replacement therapy might increase risk of clotting in your legs.
So that's my next question, which is, who's a good candidate for hormone replacement, for female hormone replacement?
So good candidates are those women that are symptomatic.
Okay.
So women that are looking at this and saying, I need a change and I need to better my quality of life. And hormone replacement therapy can do that for you. It can help with a lot of the symptoms of menopause. Those women who are, contraindicated would be active breast cancer, unexplained vaginal bleeding, certain liver diseases, history of strokes, heart attacks, blood clots, pregnant women, of course. So those women have to look at it a little bit more critically and are most often contraindicated to take it.
So what about patients who have a family history or they're BRCA positive? What would you recommend?
Well, I think everybody has to be individualized in that situation, and you have to always look at how close are the degree of relatives with breast cancer? With the BRCA positive patients, have they had a prophylactic mastectomy? How bad are their symptoms? So I would say relative contraindications to those, and really, with all kind of medications, it really has to be individualized to the individual. And also, women who are older, we generally don't start anymore on hormone replacement therapy. Women who are, within 10 years of their last menstrual period or under 60 years of age, those are usually the primary candidates that we would look to start on hormone replacement therapy.
So is there an age limit, upper age limit?
Well, I think that's, pretty much those are the constraints of what's usually done, like starting under 60 or within 10 years of your last menstrual period. And the discussion has to be with the patient who is older, because as you get older, you might have more risks of those strokes and cardiovascular disease. And those people, if they're really having symptoms that are affecting their quality of life, those are conversations you have to have with those individuals to really understand, the risks and benefits of hormones.
So I've also had some patients who come in and they're like, I have no idea if I hit menopause, because I have a contraceptive device in that is preventing me from getting my period, so I have no clue.
Right.
What do you do with those patients?
So those patients or patients who have had a hysterectomy in the past, who don't have a uterus but have ovaries, or those who have had have a Mirena in, that's a good question. I mean, certainly when they're around the menopausal transition, which would be around 48 to 52, 53 years old, and you're going to make decisions of, do we want to take the Mirena out? Are you a candidate for hormones? A lot of times those patients will have symptoms. Like they'll come in with some kind of I can't sleep, or I'm getting hot flashes, or I'm waking up sweating at night. Those are a lot of the indications that menopause might begin.
Gotcha.
If somebody is curious on that fact, or they want to act upon it, saying, I want to get the IUD removed, you can always do hormone measurements. So hormone measurements, looking at follicle stimulating hormone, luteinizing hormone, and estrogen levels are usually performed at that time to see if somebody's around that state. The caveat is that if you're in the menopausal transition, those times those hormones are a little rocky. So it's like a hormonal roller coaster. Some days you might look menopausal, some days you might look perimenopausal, some days your hormone levels might look kind of normal.
And those hormones change during your cycle, right? I mean,
and those hormones can fluctuate through your cycle.
So even someone who is maybe still getting a period, they feel like they're going into menopause, they could come in with a low estrogen level, but that's just because they're in a different part of their cycle.
Exactly. So you have to always interpret those hormones within the cycle.
Gotcha. All right. Any take-home messages for our
patients? We have take-home messages, yes. Don't be scared of hormones. I would say that if you are suffering and you're having a hard time, which a lot of women are going through this kind of transition, please advocate for yourself. Please go to see your doctor. Be open with your feelings. Be open with how you're doing so that that discussion can go on between you and your healthcare provider. There's a lot of different ways to help people that are going through a difficult transition. So don't be afraid to ask, don't be afraid to talk about it. There's different sites that you can look at that have good information that's medically sound.
Right. Don't trust Dr. Google.
Yes,
go in and get the real information.
Yes.
And if you're thinking about it, you need to meet with a specialist,
Yes.
A gynecologist
Yes.
who specializes in female hormone replacement.
Yes.
Don't just go and look on the internet and say, oh, I'm too afraid of it and it's going to cause cancer, I don't want to do it.
Right.
Meet with a specialist,
Yes.
determine your risk. Everything in life is a risk-benefit ratio, so
Absolutely.
you got to figure that out.
Absolutely. And some of the sites you can look at for sound medical advice is the National American Menopause Society. That's a good one. And you can also look at ACOG, American College of OBGYNs. So you can get some good advice there as well.
Terrific. Well, thank you very much. I hope that helps you guys that are going through menopause or perimenopause. I'm Dr. Michael Nusbaum.
Dr. Daria Klachko Totten.
And thanks for joining us at Health Talks.
Thank you.